now in this video, we're going to be talking about general pathology. So most of the part that is systemic path we have already covered, and now we are left with the first few chapters of Robbins, which are general path, which do get you a lot of questions. So the main focus, as you all know, is going to be on neoplasia, which is the biggest chapter of general path, and then we shall also be talking about cell injury, inflammation, other miscellaneous stuff, which is actually pretty important. So let's go. The first thing is the first chapter, that is cell injury. So here we're going to first talk about the signs of reversible cell injury versus irreversible cell injury. So when would any cell injury happen? So usually the onset is with hypoxia, right? So hypoxia or ischemia. What would happen is that there is no ATP because of ischemia, and because of that, the sodium-potassium ATP pump stops working. The moment that happens, now what happens is the cell starts to swell up. This is what we have learned in neurology, also in stroke. I was trying to tell you this is the mechanism of diffusion restriction. This is what is the cellular swelling, that is cytotoxic edema. So this is the first step where the onset is usually because of ischemia. So the first phase is reversible cell injury. Again, just to correlate with stroke that we have already studied, we have studied that there's something called as penumbra there, right? So what was penumbra? It was the reversible, the salvageable part. So any injury is first reversible, and then if the insult continues, it becomes irreversible. So that is what we are learning, that initially it is in the reversible phase that you see here as green. So the first change, the very first change that we call as cytotoxic edema, and that is because of the ATP pump failing, and the reason is the sodium can't basically go out. So the sodium remains inside the cell, and that is why water comes inside the cell. Wherever sodium goes, water follows. So that's the reason of cytotoxic edema. So I hope all of these concepts, are coming together very nicely. So cellular swelling is the first change. So that could be a theoretical question also. So cytotoxic edema, cellular swelling is the first change. Apart from that, what else do you have in reversible cell injuries? Ribosomal detachment. When we have ribosomal detachment, means protein synthesis can't occur. So that is what all goes down. Protein synthesis goes down. Then you have these membrane blebs which form, and you can also have nuclear chromatin clumping. Okay, it doesn't get degraded, it just clumps at this point. And then you can also have these myelin figures, which are nothing but the peroxidized lipids from the cell membrane. Okay, so you are seeing these blebs, these lipids get peroxidized, and you have myelin figures. Myelin figures is not really a hallmark of reversible alone, it can be seen in irreversible as well. So this is about reversible. If the insult continues, now it's going to become irreversible cell injury. So now you will have lysosomal rupture, you can have plasma membrane damage. So now the membrane gets damaged, and this is where now the size of the cell will get altered. Okay, so this is where the membrane damages. Nuclear degradation is very, very important. So now it's no longer clumping, it is getting degraded. And here there are three words you want to remember. First is pycnosis, then you have karyolexis, and then you have karyolysis. So these are just fancy terms to essentially say that the nucleus, the chromatin material, is now breaking into pieces, and that is what we are going to be seeing. So pycnosis, karyolexis, karyolysis is what happens in irreversible cell injury. You have increased mitochondrial permeability, and there could be these amorphous densities within the mitochondria. So amorphous densities is our buzzword here. So this is about reversible versus irreversible cell injury. Now talking about apoptosis. So apoptosis is a programmed cell death. Yeah, it's a suicide. It is a programmed cell death. The cell has planned its own suicide. Why? It could be some internal issue or it could be some external issue. Yeah. So what is the intrinsic pathway here? Intrinsic, you want to remember IN. The main caspase that is going to initiate this. So this is the initiator caspase is 9. Intrinsic, that's how you remember that this is mediated by caspase 9. Apart from that, you want to remember two things. Cytochrome C binds to APAF1. So the first word you will remember about the mediators of intrinsic apoptotic pathway, cytochrome C binding to APAF1. That's a complex. Then you can also have certain things like SMAC and Diablo. So you just want to remember these mediators here. So SMAC and Diablo, cytochrome C, APAF1, everybody is going to activate caspase 9. So eventually we have an initiator caspase 9 that gets activated. On the other hand, extrinsic, any sort of viral antigen or cancer, it can mediate the extrinsic pathways. So this is mediated by the CD8 cell, right, which are our cytotoxic cells. So the CD8 cells have Fas ligand, which binds to the Fas in the cells. This Fas can also be remembered as CD95. Okay, so Fas ligand Fas interaction is what initiates this extrinsic pathway. This you can remember as the death receptor, and here the caspases involved are 8 and 10. So you can remember 8, 10 is here and 9 is here. So 8, 9, 10 is sorted. So this is the activation of the extrinsic pathway, and who are the executioner caspases? 3, 6 and 7. So these are the smaller numbers. You know how you will see that normally the bigger people will plan things, the smaller people will execute. So here also bigger number 8, 9 and 10. 9 is intrinsic, they are going to plan, and then you have 3, 6 and 7, which are the executioner caspases, which eventually leads to apoptosis. But extra edge question here, that if you have this interaction missing, Fas ligand Fas interaction is what enables the thymus for selection of cells. Okay, so we have something called as positive selection, negative selection. I'm going to teach you that in a while. So this is the mediation of that, okay, via this extrinsic pathway. So if this interaction fails, I'm going to have autoimmunity developing, because now thymus can't do the selection of the proper cells. So the syndrome that results, okay, so there are many such named syndromes that we're going to learn in today's class. One of these is autoimmune lymphoproliferative syndrome, and this results if there is Fas and Fas ligand interaction, which is not happening, hence not allowing thymus to select the cells properly. So this is autoimmune lymphoproliferative syndrome. Next very important point here is that what is the difference between apoptosis and necrosis? This has been asked a lot of times. So in apoptosis, what you have to remember that there is no cell membrane damage. Here we saw that there was membrane blebbing, there was eventually membrane damage. In apoptosis, the cell membrane remains intact, very, very important. And you have no inflammation. In necrosis, you can have inflammation, here there will be no inflammation. So two most important changes, membrane integrity and inflammation. Remember this is very, very, very important. Now the mediators, this has also been asked a lot of times. I have a trick for you, you will never get it wrong after this. So you will remember LANT. Say it out, LAD. Anything which is an L is anti-apoptotic. That's all we need. L hai matlab anti-apoptotic. So BCL2, BCLXL, MCL, sex steroids make it love steroids. So anything with L is anti-lanti. Anything which does not have an L are pro-apoptotic. So we know this since childhood: BAX, BIM, BAD, Pluma, Noxa, P53, glucocorticoids. You don't need all of this. Essentially what you remember is anything where L is not there is anti-apoptotic. Right? So this also helps you remember, where did we study BCL2? Go back to your hemat folder in brain and tell me where did we study BCL2. 2 matlab good prognosis. What was good prognosis? Follicular lymphoma. Yeah. So follicular lymphoma is BCL2 activation. Why activation? Because it is anti-apoptotic. Yeah. So anti-apoptotic, when it gets activated, there will be a lot of cells. So that's how follicular lymphoma happens. Yeah. So this is about the membranes. A little more extra. So we have a few markers, what gives a cell a signal of apoptosis. This is called as eat me signal. So the cell is going to give a signal that eat me, I don't want to live, I want to commit suicide. So what is the signal of that? The signal of that is this: phosphatidylserine flipping. Okay, so the phosphatidylserine from the cell membrane now flips, and that is a marker that the cell is going to die. Okay, save the cell. This is that signal. So this is what is annexin V. So annexin V, we have studied this when we were studying hairy cell leukemia. I told you annexin A1 is hairy cell leukemia. Annexin V is a marker of apoptosis. So what are the markers of apoptosis? You can remember this as phosphatidylserine flipping, annexin V, and we use a stain called tunnel stain. These are all very extra edge questions if this comes party. Yes. Apart from this, you can also be given this membrane gel electrophoresis. This is what viable cells look like. Whenever you see that there is this step ladder sort of a pattern, this is what it's described as. This is the hallmark of apoptosis. Whereas if you see this smearing of pattern, it indicates that the chromatin has degraded into multiple products. That smear pattern is for necrosis. Yeah. They're not specific, but for exam purpose, we will remember it as this only. Now, there are certain special types of updates here as far as the other necrosis are concerned. So, whenever you are talking about RIPK1, MLKL phosphorylation, whenever you hear these big words, what are we talking about? Necroptosis. Okay, so this is necroptosis. Caspase 1, 4, 5, and 11. Caspase 1 you will remember as interleukin 1. What does interleukin 1 lead to? It leads to fever, right? So, fever se yaad rakhenge pyro. So, this is pyroptosis. So, caspase 1, IL1. That's how you remember. And whenever iron comes in, obviously it is ferroptosis. So, they will not ask you about iron, they can ask you about this. So, this is the type of apoptosis, which is lipid peroxidation or Fenton reaction. So these are other variants of apoptosis or programmed cell death. Okay, so this is not necrosis, this is programmed cell death, that is apoptosis. So these are the variants, the newer recent advances might be asked. Okay, so this is about the cell injury thing. Now let's talk about inflammation, second chapter, Robin. So inflammation, what are the sequences? This is something which is very easy. We have already done this. So the first change is vasodilation, right? So this is a little controversial where, when you study your notes, it might be written in certain places that the very first change that happens is a transient vasoconstriction. Okay, so this transient vasoconstriction is not mentioned actually. I've checked, Robin's also checked first aid. It's not given, but it's given in most of the notes. So you can remember it with, a pinch of salt. That is, this is there in the option market. Otherwise, leave it. Yeah. So transient vasoconstriction, of course, which is the very first change, followed by vasodilation. So actually, what is the lasting change is vasodilation. So this is what happens. So transient vasoconstriction, then vasodilation, and then what have increased permeability. This is important. So increased permeability, and this is a very extra edge point. Okay, if you answer this correctly, it gives you an edge because it's straight up from Robbins. So when you have increased permeability, the mechanism could be either endothelial cells retracting or there is permanent injury. What are the causes is important. So the retraction is induced by histamine, and this is very transient. Whereas endothelial injury is caused by thermal burns, microbial toxins, and this stays. Okay, so this is pretty simple but can be tested. Okay, so this is about retraction and endothelial injury. This is followed by extravasation. So now you have gaps, right? So now we are going to have extravasation here, again mediated by histamine, and the site where this happens is post-capillary venules. So this also sounds like a very important point. Where does all of this happen? It happens in the post-capillary venules. So now let's dwell deeper into this extravasation. What are the sequences of events, and that is what is asked. So the first event that happens is margination and rolling. Once the WBC gets a signal that okay, inflammation here, we have to go somewhere, the first thing they do is they start attaching to the endothelium. So they start getting marginated and they are rolling onto the endothelium. What enables this to happen are selectins. So we have E-selectin on the endothelium, T-selectin also in the endothelium, which come from the Weibel Palade body, if you remember from hemat. So these selectins are there, then they're acting as receptors. So to this, you can see how the neutrophils with their carrots are binding onto this receptor. Okay, so this is how margination rolling happens, and this is meant by selectins, and they bind to the silyl lubis X. Okay, so the silyl lubis X is the compound here that is enabling this binding. The other name of E-selectin is CD62, little extra, not needed. So this is what is happening here. Now, when you don't have the silyl lubis, right, so it is mediated by an enzyme called fucosyl transferase. So when you don't have silyl lubis X, now this margination rolling doesn't happen, and this is what leads to leukocyte adhesion deficiency 2. Even though this is the first step, so this is where it gets tricky and students make a lot of mistakes. Even though this is the first step that is happening, the LAD is LAD2. Okay, 2 is B is second letter, so 2 is B. So you remember the LAD2 is associated with Bombay blood group. So this is leukocyte adhesion deficiency 2. The second step is the binding. The binding is mediated by integrins. So this is where you are going to have binding of the integrins. So the integrins here are basically LFA1 that binds to ICAM1. So we have ICAM1 and VCAM, which are going to take the neutrophils, and this is what is the type binding. So here you have CD11 and CD18, which could be deficient, and when this is deficient, this is what is LAD1. So essentially, don't remember everything, just remember that everything in LAD1 is a 1, LFA1, ICAM1, integrins, 11, 18. So that becomes very easy. You don't even have to memorize anything. You just see a 1 and it is LAD1. LAD1 now, because there is no binding, what happens? There is not going to be any pus because eventually the neutrophils just couldn't reach the site of the inflammation. So in LAD2, another buzzword that we need to remember here is that there is also going to be delayed separation of cord. Okay, so this is another point that can help you reach a diagnosis of LAD1, that is delayed separation of cord. So there is no pus because there is no migration of the cells happening because they're not able to bind. So that's why there is no pus here. Apart from that, while we are on LAD, just to finish off, there is a rare type which is LAD3. That's the least common type. From 3, you will only remember that this is a defect of formed 3, which is also going to help in the migration. Okay, so that is what is missing here. So this finishes off leukocyte adhesion defect. Now, just to get back into the orientation, so the first step, the stepwise arrangement has been tested. The first step is mycination and rolling, which was with selectin. The second step is binding, which is with integrin. Third step is diapetesis. So this is where through the endothelial cell gaps that were made, now the neutrophil migrates. And this is very important. This is a question that has a very high potential to be asked. That is via PCAM1, and the CD marker of this is CD31. Okay, so this is how the migration now begins. Where do they have to migrate? So they are guided by what are called as chemokines. So chemokines are going to take them where they are needed. So this is what is happening with WBCs in any inflammatory event. So now let's have a look at all of the cytokines in one place. It's very important. You have to revise this table again and again. So you know how we have different T cells. So first of all, before even I go into this, just a primer on a little bit of immunology. So whenever you have any antigen presenting cell, that is going to come and activate the T cell. So this is how the T cell gets activated. Either it mounts a Th1 response or it mounts a Th2 response. T helper cell 1 is what is responsible for our cell mediated immunity, where you have granuloma formation. T helper cell 2 is when you have a humoral immunity, where essentially we are going to have immunoglobulins forming. Okay, so this is what is happening. What are the antigen presenting cells? So an independent question, what are the antigen presenting cells? So one, we have these dendritic cells, right? So we have these dendritic cells. Dendritic cells could be Langerhans cells or dendritic cells within the skin. So this is what is antigen presenting cell number 1. Then you can have macrophages, which can be antigen presenting cell, and then you have B cells. So B cells could also be antigen presenting cells. You can remember DMB, yeah, if that helps. So you know DMB is a degree. Now we have DMB. So dendritic cells, macrophages, and B cells are antigen presenting cell, then T cell, and then you have these. So what does T helper 1 cell produce to mount a cell mediated immune response? So these are the 3 cytokines which are produced by Th1 cell: IL-2, IL-12, and interferon gamma. So it is interferon gamma, G for granulomas. That's how you will remember that this is how a granuloma is formed. This is how cell mediated immunity happens, by activation and release of IL-2, IL-12, and interferon gamma. While we are talking about interferon gamma, let me go on another tangent and just finish off all of the interferons for you, right? So the aim here is to just give you all the information in one place that we can interlink and form synapses, okay? So we have interferon alpha, beta, and gamma. So these are the 3 interferons that we have, right? So here you can remember who produces them as LFT. It is produced by LFT. L for leukocytes. So leukocytes produce interferon alpha. B for fibroblasts. And T for Th1, as we just saw, produces interferon gamma. So this takes care of who is producing them. So LFT, alpha, beta, gamma. And that also gives you an idea about what they form. Question 4. Just to give you the treatment aspect also, we use all of these for therapy. So interferon alpha is used for viral, right? So it's used as an antiviral. We have studied this in hepatitis B, where interferon alpha is used. Interferon beta is used in multiple sclerosis. Again, I've mentioned this in neuro. So interferon beta matlab two letters means MS. That's how you will remember. And gamma, it produces granuloma. So I can use it in chronic granulomatous disease, right? Immunodeficiency, I can use it. So this is about the interferons. Okay, so now going back, so we were at T helper 1 cell, which were producing granulomas and cell mediated immunity. What does a T helper 2 cell form? So Th2 is going to form all of these cytokines: IL-4, IL-5, and IL-13. Now what does IL-4 do? So 4, what you want to remember, if I have to make IgE, look at E, 1, 2, 3, and 4. So you remember that IL-4 increases the level of IgE, whereas IL-5, eosinophil, E is the 5th letter. So that is what is IL-5. So why I have to do all of this painful mnemonic creation? Because both are E's, right? So you get confused. So remember, capital E, we make it with 4 limbs. So that's IL-4, whereas IL-5 is going to be eosinophils. Okay, and IL-13 is miscellaneous, like phagocytosis, mucus production. So that is what it does. So this is about Th1, Th2, the humoral immunity, and the cell-mediated immunity. Few more cytokines. So we have IL-1, 6, and TNF-alpha. So these are your pro-inflammatory cytokines. These are your pyrogens, right? So IL-1 and IL-6 are the main pyrogens that you have to remember. Then you have to remember, very, very important, IL-10 and TGF-beta. This is beta. So you'll remember thus, and then thus with B. So bus. So they are saying bus to inflammation. Matlab bus, anti-inflammation. They stop the inflammation. Inflammation, bus ho gaya. You'll remember beta and thus. And there is lipoxin as well here. Very important list again are for chemokines. So here we have all of the chemokines. So this will remember simple math formula. 4 plus 5 equals 8. It is 8 only. We were taught wrongly in school. It is 8. So 4 plus 5 equals 8. So that's what we remember. We have LTB4, we have C5A, and we have IL-8. So that's how we remember the wrong math formula. But that will help here. So 4 plus 5 equals 8. So this is sorted. And then we have kallikrein and 5-HTE. So these are all the chemokines. Another important is, you're seeing this is all so important, this box has to be seen multiple times. Put it on a stick it and put it on your wall. Okay, so you have to see this again and again. C3b and IgG are your opsonins, so they are going to coat the bacteria and they're going to phagocytose in the spleen. So that's how it happens. And C3 and C5 is the easiest. A for A, these are anaphylatoxins. Okay, so this is what we will remember. We have simultaneously done the functions of a lot of complements as well. Okay, so this is all about inflammation. Now let's talk about granulomas. We said interferon gamma, T helper cell 1, cell-mediated immunity. So what are the types of granulomas? Since the last 2 years, every exam you're getting this image of a granuloma and they're asking you to diagnose it. So first of all, look at this pinky material in the center. So whenever you see that there is this pinky material in the center followed by a cup of cells, which are all your inflammatory cells, this is what is a typical caseous necrosis. So this is a caseating granuloma, cheesy material, caseating granuloma, hallmark, one and only TB. Yes, so caseating is tuberculosis. When you don't see the central necrosis, all you have are the cells. So this is what is a non-caseating granuloma. You do have a cup of cells, inflammatory cells, but there's no central pinky material. That's what you'll remember as non-caseating granuloma. So where do we see non-caseating granuloma? So sarcoidosis. Then we have Crohn's disease, where we have non-caseating. Histoplasma can have both. Okay, so we say that histoplasma makes TB, right? So it can have both. So we don't really need to mention it. Few more features. Histiocytes in gamma is a feature of tertiary syphilis. So gammas are also granulomas, and that's in tertiary syphilis. Very important question. Cat scratch disease has stellate granulomas. This will also study in microbiology, right? So cat scratch disease has a stellate granuloma, and this is what it looks like. So this is what is an image of a stellate granuloma. Hasn't been asked so far. Might be asked. Then you have Dirk granuloma, again important. Okay, so hasn't been asked. So Dirk granuloma is for malaria. So just to give you an image perspective, this is what it looks like. So this is Dirk granuloma, and this stain can be asked. This is what is called as the field stain to demonstrate the Dirk granuloma of malaria. And donut granuloma or a ring granuloma. Look at this, exactly like a donut. So this donut granuloma is seen in Q fever and also with allopurinol. Okay, so Q fever, allopurinol is a donut granuloma. So this is Q fever or allopurinol. Right, so this is all about the granulomas and their images. Pretty important. Even if you forget everything, don't forget the image of caseous necrosis, caseating granulomas, pinky material in the center. This is what the giant cell looks like. So these are the Langerhans giant cells. These are not Langerhans, these are Langerhans giant cells that you frequently see in granulomas. They have this horseshoe ring arrangement. Sure, you remember this from the second year. Okay, here is just an extra list of all the other diseases which may show you granulomas, which you otherwise wouldn't have known. So listeria can cause granulomas. Okay, so that's a fun fact. Schistosomiasis can cause granulomas. Chronic granulomatous disease, I don't really need to tell you, so the name itself. Primary biliary cirrhosis may have granulomas. Then the vasculitis. So GPA, EGPA, I think you already know because the name is granulomatosis with polyangiitis, that's Wegener's. EGP is eosinophilic granulomatosis with polyangiitis, that's Church-Strauss. And then Takayasu. So remember, Takayasu also has granulomas. De Quervain's, remember De Quervain's thyroiditis. What did we remember in surgery? De Quervain. Vein matlab pain. So this is painful granulomatous thyroiditis. Then occupation-related disease, I can mimic sarcoid. We studied this in RESP, is borreliosis. HSP may have granuloma. So in this lecture itself, I teach you there is both type 3, type 4 hypersensitivity. Type 4 hypersensitivity means granulomas. Calcosis is another disease which may have. So essentially, all of the things we are studying on this page are examples of type 4 hypersensitivity because cell-mediated immunity, granulomas, matlab type 4. So even if you get, even if you forget and get confused in the exam, whatever we are seeing on this page is essentially type 4 hypersensitivity. Right? So this is about the inflammation. Just to further strengthen whatever we have studied and get a pharma perspective into things, I'm now going to teach you very, very important immune checkpoint inhibitors. So here what you have to remember, that we already said, right, that there's going to be an antigen presenting cell and that is going to activate the T cell. How does that happen? So all antigen presenting cells have MHC2. Remember that? We'll go to MHC in the next page. So all antigen presenting cells have been given MHC2. We already know what are the antigen presenting cells. They are going to bind to CD4. With this, you can also remember the rule of 8. What is the rule of 8? The rule of 8 just tells us that 2 into 4 equals 8 or 1 into 8 equals 8. So CD4 is going to bind to MHC2, whereas CD8 is going to bind to MHC1. Yeah, so you can see here how MHC1 is going to bind to CD8 cells, right? So this is what can activate CD8 cells, whereas MHC2 antigen presenting cells are going to come to CD4. This also helps you remember the ratio of CD4 to CD8, which is normal, and that is 2:1. So again, 4 2s are 8. And this we have studied in sarcoid, where this ratio further increases to around 3.5 to 5:1. Okay, so this is what is the rule of 8 here, immensely helpful. Right, so we have this primary signal. So MHC and CD is the primary interaction. We also have a co-stimulatory signal, and here again maths helps us. 4 7s are 28. Okay, what? So B7, 28. So ignore 4 or don't ignore 4. Here is 4. So CTLA4 and CD28 are both fighting for the affection of B7. If B7 and CD28 interact, this is when the T cell is activated. But when CTLA4 binds, it is an inhibitor here. Okay, so this is what is happening. Apart from this, we have these two things, PD1 and PDL1. If they bind, they are again going to inhibit T cell activation. So now, what can I do? Let's say we have a tumor, okay? Can I use my own immunity to kill that tumor? We can. So what we are here trying to do is we are inhibiting the inhibitor. Inhibit the inhibitor of the T cell activation. So that is what we are doing. So I can either inhibit CTLA4 or inhibit PD1, PD-L1. Either ways, I'm now activating T cell and we are using our own body to kill our tumor cells. So that's the concept of immune checkpoint inhibitor. A lot of people misunderstand this and they think that these are immunosuppressants. No, these are activators of our own immune system. So this is what is the most important concept. Then the names are pretty easy here. So look at this. CTLA4 inhibitor in pink. You can see ipilimumab. This is an important drug, hasn't been asked so far. You want to remember this is for melanoma and can also be used for RCCs. So ipilimumab is used for advanced melanoma and RCCs. Then we have our green, which is PD1 inhibitor. Very, very important. You will remember them as pencil drugs. So what are your pencil drugs? Pembrolizumab, nivolumab, semilimab. Don't even bother. Remember pencil. Pencil matlab PD1. Okay, in grade 1, you write with a pencil. Fine. So PD1 matlab pencil. And then you have the PD-L1 inhibitors, atelozumab, durva, adalimumab. So again, you don't really have to bother with this. Just remember the names and the various applications are melanoma, Hodgkin's, non-small cell CA lung, urinary bladder, and Merkel cell CA. Out of this, they have tested about non-small cell CA lung and the use of pembrolizumab. So pembrolizumab has been used in non-small cell CA lung along with chemotherapy, and that trial was Keynote 189 trial. So there's a question on that. Pembrolizumab plus chemotherapy for CA lung. Apart from that, pembrolizumab can also be used for CA endometrium, and that's a repeat question. So they love asking pembrolizumab for certain reasons. Okay. Now, while we're talking about T cell receptors, right? So T cell receptors normally are the alpha and beta chain that are going to bind to the MHCs. But what you want to remember that there can also be gamma and delta chains, and this becomes a part of innate immunity rather than acquired immunity. And this is present in the genitourinary and the GI system. So just one thing I want you to remember: G and G go together. So GIGU is gamma delta. That's all. So this finishes off a very, very important topic of immune checkpoint inhibitors. And along the process, without you realizing, that actually covered a lot of immunology already. Just to take that further one step ahead, now let's talk about an independent topic of MHC, and then we talk about immunoglobulins here. Okay. So this is what is MHC. So you need to know the structural difference between MHC1 and MHC2. We have already discussed what they bind to, right? MHC1, what you have to remember, is present in all of the nucleated cells of the body and also platelets. Platelets don't have a nucleus, yet they have MHC1. The only cell which doesn't have are RBCs, and you can also remember another point, which is sperms. So RBCs and sperms are the cells which don't have MHC1. MHC2, on the other hand, you want to remember that these are only present in antigen-presenting cells. So this is about who has them. What they bind to, we already know thanks to rule of 8. So MHC1 is going to bind to CD8 cells, and MHC2 is going to bind to CD4 T cells. Okay, so this is about 2 4s are 8, and 1 into 8 equals 8. Right, now let's see the image, and this has not been tested in the recent past, but seems like a very important potential question to me. So look at this. First of all, MHC1 is made up of 3 alpha chains: alpha 1, alpha 2, alpha 3, and then there is a separate beta 2 microglobulin. Okay, so that is what is the first point. And what is the antigen binding group? It's between alpha 1, alpha 2. That's all we need. Now look at MHC2. This one has alpha 1, alpha 2, beta 1, beta 2. And the antigen binding site here is between alpha 1 and beta 1. So you remember here it is alpha 2, whereas here it is beta 1 along with alpha 1. Okay, so this is all that we need from MHC. Now let's talk about immunoglobulins. So we mounted a humoral immunity and we want immunoglobulins now. So this is what is the prototype of an immunoglobulin. You can see here that in green are the light chain and this is the big heavy chain. Now what you have to remember, this where you see the epitope. Epitope is the specific antigen binding site. So here what you are seeing is the antigen binding site. So you can see this antigen binding site, and this is by both light and heavy chain. So you can see both light and heavy chain participate in that. So that's the first thing. Now the specificity. Every immunoglobulin is specific for a single antigen. So who gives the specificity of the antigen binding site to an immunoglobulin is the process that is called as affinity maturation or somatic hypermutation. Don't worry, it's all okay. We'll just remember 2 big words: maturation, mutation go together, and this is what increases the specificity of the antigen binding site on an immunoglobulin. Yeah, that is all we need. This has been asked way too many times. Okay, so this is about the first thing. Now look at the heavy chain here. So you can see that in heavy chain we have CH1, CH2, CH3. It's a question. It's a USMLE question actually. That what does CH2 do? It is complement binding. So CH2 is complement binding, whereas both 2 and 3 are for macrophage binding. So more important is complement binding. So this is what we have learned. Now the primary immunoglobulins which we have on a B cell, right? On a B cell, the primary immunoglobulin that we have is MD. What are all of you studying for? An MD degree. It's already there with a B cell. Done there. So MD is what are the primary immunoglobulins. Now, whenever there is response, now we are going to have the secondary immunoglobulins, which are your others. So IgA, IgG, and IgE. So these are the immunoglobulins that are later produced, and this process here is what is called as isotype switching, and this happens because of alternate RNA splicing. So this is what is the isotype switching. From MD, it makes the other 3. Okay, this happens because of interaction of CD40 and CD40 ligand. If this interaction doesn't happen, now what is the immunodeficiency that we have? I'm only going to have IgM or DD is very little, so we don't care. So predominantly I have IgM and I don't have IgG and the other immunoglobulins. And that's why when this is defective, what we have is hyper IgM disease. Yeah, so that's the immunodeficiency disease there where you only have IgM, no IgG. So I hope you understood this entire process of immunoglobulins and the immunodeficiency disorder, hyper IgM disorder. So this is what we had to understand here. As far as the concentration of immunoglobulins is concerned, I've already told you while I was teaching you multiple myeloma that it is gamma, IgG more than A, more than M, more than B, more than E. So this is the same in multiple myeloma as well, same here as well. Okay, so this is normal serum concentration of all immunoglobulins. You already know IgM is a pentamer. There are 5 chains. You know IgA is a dimer along with a connecting protein that is called as the J chain, right? So this is the dimer and IgM is pentamer. So these are the points that I'm sure you already knew. This is a very weird theoretical question that if I break an immunoglobulin using pepsin, what will happen? And if I break using papain, what will be happening? So when you break with pepsin, it is this particular site here where the chain breaks. So you can see this part here, the disulfide bonds, that is what breaks. So this is what happens when you have pepsin attacking. On the other hand, when papain attacks, you will have 3 parts. Both of the FAB go separately and FC comes separately. So papain, 3 parts, pepsin, 2 parts. So you'll share Pepsi with 2 people, not with 3. Okay, 3 becomes too much. You will not get anything. So Pepsi only with 2 people, but Papa you can share with 3 people. Okay, so that's how you can remember about immunoglobulins. I do finishing of immunology. Let's now talk about complement pathway. So here, pretty basic stuff, that they don't really ask you. They ask you all of these other boxes that I'm going to discuss, but just to finish it off, we have the classical pathway and the main mediator here are the antigen-antibody complexes. And here, the main complements that you have is going to be C1. Okay, so here the main complement you have is C1. Then you have the lectin pathway. So this is basically microbial antigen activation. So whenever you have microbial antigens, they have mannose on them, and that binds to lectin. Okay, so lectin mannose, this is for microbes. So M and M mannose, L and N stick together. You will soon know when we go to microbiology, you will realize how L and M are an inseparable pair. So this is what is the another place where L and M go together. Here the complements are C4 and C2, which are the main ones. Alternative pathway is for pathogens, injured tissue, and this is where the main is 3. So we have dealt with all of our early complement 1, 2, 3, 4. 1 is the main one for classical, 3 is alternative, and 2 and 4. Yeah. Both even numbers go together are for lectin. So eventually all of these together, C3b and all of these together activate C3. C3 when it becomes activated becomes C3a, right? Then you have the activation of C5. C5 is our main terminal complement, and that is what forms the membrane attack complex with C5b to C9. So just remember, early complement 1, 2, 3, 4, terminal complement C5, and then a membrane attack complex. So this is how complements work. Few questions. What is the most common complement deficiency? That is C2. Next, what will happen if there is early complement deficiency? You have autoimmune disorders like SLE. What will happen if you have terminal complement or membrane attack complex? And this is a very, very important question. USMLE favorite. I told you this in last BTR. In NEET 2024 had a question on this. This is very, very important. You can see like direct signatures that they are getting influenced by USMLE question banks a lot. Okay, so that's the way forward for all of us when we are preparing. So terminal complement or MAC deficiency, membrane attack complex deficiency, is what leads to disseminated Neisseria infection. So this is where you have a lot of Neisseria infection. You can have meningitis, you can have Waterhouse-Friderichsen syndrome. I'm going to teach you all of this in micro. Okay, and then very important, C1 inhibitor deficiency results in a disorder called hereditary angioedema. So hereditary angioedema, you're going to have swelling of the lips, you're going to have laryngeal edema, you can have laryngospasm, asphyxia as well, which can result in severe cases. So this is hereditary angioedema. Few markers now. So you know the easy markers like CD4, CD8, pan T cell marker is CD3, then you have pan B cell marker as CD19, 20. So all of this we have done in HEMAT also directly, indirectly. I'm just teaching you the few ones which are important. So 1656, I think everybody knew, and that's why AIMS decided to ask the one which nobody knew, that is CD94. So they picked up 94, is not given anywhere in the basket. So 1656, 94 is NK cell. 41, 42, 61, this has not been asked. This is purely my instinct that I'm trying to share. So this is mega karyocyte markers. Leukocyte common antigen is CD45. Don't confuse it with CALA. CALA is common leukocyte antigen. So this is CD10, right? So don't expand it, otherwise you'll get confused. So just remember, CALA is CD10 and leukocyte common antigen is CD45. So now let's talk a little bit about what thymus does. Okay, so thymus has to make sure that whatever T cell it is producing first should be able to react to antigen presenting cells and process the immunity, but we also have to make sure that it doesn't react to self antigens now and cause autoimmunity. So both of those responsibilities it has, which it does in 2 processes. So first what it's going to do is positive selection. Here it recognizes what all T cells can bind to self antigen. So the thymus doesn't have any foreign antigen to experiment and see if they can bind to foreign antigen. The only antigen it has is self antigen. So it will check that can you bind to self antigen? If you can bind means okay, you can bind to foreign as well. So this is what it checks, that are you able to bind to a self antigen or not. So this is what is positive selection. So they are selected, they go to the next stage. Now see what it does. The next stage, now it recognizes the T cells, are they binding too strongly to the self antigen? Do we want these guys who bind too strongly? We don't really want that. So this is where you now eliminate them. So now thymus recognizes them and it deletes them, hence negative selection. So this is how it eliminates autoimmunity. I'll give you an example that you might relate to. If you're looking for a life partner, there are going to be 2 things you have to fulfill. First, they should have enough emotional maturity that they can bind to you. So utna hona chahiye that they can bind. So that is what is positive selection. That little emotional quotient is necessary. But it shouldn't be so high that they stick to you all the time. Yes. So this is what, there is a Hindi word for it, which I will not use. So what you have to remember here, that we don't even want very, very chipku people, right? So you don't want too strongly also. So this is negative selection. So this is how you will remember, because the thymus also does the same. It is going to recognize the cells which can bind, have enough EQ, but you don't want very, very high EQ also. Okay. So this is what is negative selection. Now imagine somebody couldn't do the negative selection. This AIRE gene is what is responsible for the negative selection. So when you have AIRE in thymus, right, which is mutated, the syndrome that is going to result, right, when a negative selection doesn't happen, the syndrome that results is going to result in polyendocrinopathy, and you're going to have mucocutaneous candidiasis. Okay, so this is what is Candidiasis. Okay, so this is what results if there is no negative selection happening in the thymus, right? So here you're going to have endocrinopathy where you have a lot of autoimmune diseases and you have mucocutaneous candidiasis. Okay, so the buzzword here is candida because polyendocrinopathy is going to confuse you with the next thing I'm about to teach you, right? So far, AIRE is candidiasis. Agar thymus doesn't do negative selection. That's the point here. Now there are these, we already studied TH1, TH2 cells. There are another group of cells which are T regulatory cells, which are the monitors. They're just regulating whether everything is going on well or not. They have a marker called FOXP3. If that is defective, now you are going to have IPEX. Why I have kept it together is because both will have polyendocrinopathy and you will confuse them. So that's why I've kept them both in the same table. IPEX is immune dysregulation, polyendocrinopathy, enteropathy, etc. There's no candida here because that's what I wanted to focus on. Focus on candida. Candida matlab thymus ke negative mein problem. No candida matlab T-reg cell mein problem. Right? So this is about all of these big names. So now I taught you 3 big names in total. Remember the first page, which seems a very distant past. The fast ligand interaction was not happening. So that was autoimmune lymphoproliferative syndrome because no apoptosis was happening. And then I taught you 2 syndromes. One is AIRE, one is IPEX. Okay. Right. Now, other immunodeficiency disorders. So here we are going to go stepwise. This is the most important. Look at this cute baby. So this is Wiskott-Aldrich syndrome. From today, we will call it Wiskute-Aldrich syndrome because the baby is cute. Imagine this baby wearing a tie. The baby will look cuter. And who is this baby, boy or girl? It has to be a boy because this is X-linked recessive. NEET 2024 question. So cute baby wearing a tie. The baby has thrombocytopenia, infections because immunocompromised, and the baby has eczema because of high IgE. Whenever IgE levels are high, you're going to have eczema. So remember, cute baby wearing tie, thrombocytopenia because of that. The baby, look at the baby. Baby has so many, but you get. So this is Wiskott-Aldrich. The next one, remember this boy. You know the age of this boy? This boy is 17 years. So this is TH17 defect. So this is what we call as job syndrome. This boy wants a job at 17. And look at his feet. It is his feet to do a job. So he has abnormal facies, cold abscesses. So this can be cold abscesses. There are teeth. The primary milk teeth are retained here, and again eczema and Ig. So 2 diseases where Ig levels are high and there'll be eczema. One is cute baby wearing a tie. Second is a baby who's 17-year-old wants a job and that's his fit. Yeah. So this finishes off high Ig story. Third very important disease you want to remember is a phagocyte defect. So this is where you don't have the microtubules, and this is because of a defect in the list gene. So the phagolysosome fusion doesn't happen and phagocytosis doesn't happen. The marker here is this albinism. So you're going to see albinism, so light babies, and you will also be given platelet or neutrophil dense granules. So 2 buzzwords, albinism, platelet granules, neutrophil granules. With any immunodeficiency, what are you going to think of? What are we talking about? We're talking about Chidiac Higashi. So Chidiac Higashi, if you want a mnemonic, you can remember LMNOP. L for list and light color, M for microtubule defect, N for neurodegeneration, O for phagolysosome, and P for platelet and neutrophil dense granules. Okay, so you can remember mnemonic, but I will advise you don't remember mnemonic. Have a pictorial memory. All of these pictures, should come to you. Okay, slide ke top pe 3 babies the, 2 were Ig, 1 was light baby, like that. It has to happen. Okay. Now we come to the most severe infections. Whenever they give you since birth, yeah, it means it is a T cell defect. Okay, so it's a T cell defect because it happens since birth. If they give you after 6 months, it's a B cell defect because immunoglobulins can be maternally transmitted, hence B cell defects present after 6 months. Since birth likha hai means it is T cell. So that's how you know. What I'm talking about, the most severe infection, that is SCID, severe combined immunodeficiency. Now the most common mutation here is with the IL-2 receptor. This is an X-linked recessive inheritance. What can also be tested is adenosine deaminase defect, which is autosomal recessive. So you can remember that A and A are together, whereas it is not together here. Because there are no T cells, there is no thymus. So very, very important, they'll tell you on the X-ray, in a child normally we see a big thymic shadow, but here there is no thymus shadow and you have no germinal centers because there are no T cells. So this is what we are going to get in SCID. Another T cell defect, we will study this in anatomy, it's a pharyngeal pouch defect. Which pharyngeal pouch? The 3rd and 4th pharyngeal pouch. 3rd and 4th pharyngeal pouch are the ones which are going to form the thymus and the parathyroid glands. What am I talking about? I'm talking about DiGeorge syndrome, which is a 22q microdeletion. Now there is a catch-22 mnemonic here, but I don't want you to go into that. I want you to know the specific points. Here you don't have thymus and you don't have parathyroid, and that is all you need. The 3rd and 4th pouches are not there. Thymus nahi hai, so no T cells. PTH nahi hai, so no calcium. So there is going to be hypocalcemia. The moment you hear these words, you don't need the rest of the catch-22 because that's all very non-specific. You have abnormal facies, you have cardiac effects. I don't care. My answer is going to be made by these 2 only, so that's what you need to know. So this is the moral of the story of how you have to prepare, right? So there is going to be so much stuff. Find the ones which needs your attention from that. Find that buzzword. Long story in the form of a question comes. Find the part that the examiner is telling you. Focus on this. This is the buzzword. Ignore all of the fuss around it. So this is what we do here as well. There will be a lot of stories, a lot of mnemonics which will be written. Can I remember everything? You might feel right now that, yes, I will remember. In the end, you will not be able to. So trust me on this. Remember the buzzword. So that's what we do here. Now, what is the approach to B cell? So when you don't have the main BTK, this is Bruton's tyrosine kinase, then no B cells are formed. So as I said, B cells will present after 6 months with recurrent infections. All immunoglobulins absent because no B cell, and now the germinal centers and tonsils will not be there because tonsils have the B cells. So this is what is Bruton's A-gamma globulinemia. And as the name suggests, this is where you have no immunoglobulins, B for Bruton, B for boy. So you remember this is also acting recessive, like this called Aldrich. The other disease that you have is BAF. So this is common variable immunodeficiency. As the name suggests, this is variable presence in adolescents. All immunoglobulins are low, and you have hyperplastic germinal centers here, not absent. And lastly, the most common immunodeficiency is selective IgA deficiency. In selective IgA is a mucosal immunoglobulin, right? So when that is not there, Giardia uncle. You'll understand why I'm calling Giardia uncle in microbiology. So Giardiasis will take advantage, and you can have recurrent Giardiasis, and also IgA leads to more anaphylactic reactions after receiving blood transfusion, and this we have studied in hemat as well. Remember, A for IgA, A for anaphylaxis. So this is what we need to remember about all immunodeficiency disorders. Moving on to a very, very important topic now, that is amyloidosis. So amyloid, first of all, you have to remember that it's going to be an extracellular eosinophilic material, right? So when you are doing a simple, light microscopy histopath image, it's going to appear pinky extracellular eosinophilic material. This has been asked a lot of times in the context of restrictive cardiomyopathy. They've asked this to you in context of medullary thyroid CA. So they can give you this image. What they represent are these beta-pleated sheets. Okay, so these are the general points. The specific stain that we use, and I'm sure all of you know, that is the Congo red stain. Congo red stain, when you look at it under light microscopy, the amyloid deposition is going to appear salmon pink in color. Whereas if you look at it under a polarizing microscopy, you're going to see this apple green birefringence, and I'm sure all of you know this like very well from profs, right? So this is what is about amyloid. What are the more important questions here are, what is the fibrillary protein that gets deposited? Before I go into the proteins, remember the most common organ affected by amyloid are the kidneys, and we have seen that appearance as waxy kidney in renal. But what is the most specific organ is the heart, and there we see a restrictive cardiomyopathy pattern, which is also a repeat question. Okay, now let's go to the fibrillary proteins. So primary amyloidosis happens with multiple myeloma, where the light chains form this amyloid. So this is the AL amyloid deposition, and you also know these light chains come into the urine as Jones proteinuria. So I'm not writing that, just remember it. And this is multiple myeloma. Secondary amyloidosis is where you have chronic inflammation. So any chronic inflammatory pathology is going to lead to it. For example, rheumatoid arthritis. You can have malignancies like RCC. Just can remember, even though not very, very important, that all chronic inflammation, but not bronchitis. Okay, so not chronic bronchitis. It's one thing which does not lead to secondary amyloidosis. And the chain here is the AA chain. So not AL, but AA chain in secondary amyloidosis. And this is chronic inflammatory pathology. Also, if you remember, there is a condition called familial Mediterranean fever. Okay, this is not relevant to us, but you just want to remember there's a mutation here where you have very high levels of IL-1 and IL-6, which are your pyrogens. So familial Mediterranean fever, because so many pyrogens, so many inflammatory cytokines, you have a deposition here as well. Okay, so just to give you that context. What I feel is very, very important and can be tested is dialysis related, where you have amyloid of beta-2 microglobulin. Okay, so this is beta-2 microglobulin deposition. Same beta-2 microglobulin we have also studied in multiple myeloma, where I told you this is the prognostic factor. Okay, so that's a relation there. Alzheimer's disease, we all know are amyloid beta chains. Type 2 diabetes, I told you in endocrine, this is islet associated polypeptide. Don't remember full form, just remember IAPP. Medullary thyroid CA, what's the tumor marker? It's calcitonin. So here, amyloid of calcitonin is formed. Isolated atria. Atria produces atrial natriuretic peptide, so that's AMP here. Now, there are two amyloid chains of transthyretin. Okay. In senile amyloidosis, when an old person, when they become very wild, what do we say? We say that this old man has become very senile. Remember that wild TTR is senile amyloidosis. Okay, so wild matlab non-mutated. Any non-mutated form is called as wild. Okay, but if the transthyretin is mutated, that is what is going to present as polyneuropathy. So this is what we have to remember about all of the fibrillary proteins. Simple, straightforward questions. Don't get this wrong. Very well scoring. Okay, so this is about amyloid. While we are here, I wanted to talk to you about the serum protein electrophoresis. So this is how our normal serum protein arrangement appears. So we have the biggest spike here by albumin, because that's the most common protein. Then you have alpha-1, alpha-2, beta, and gamma. Starting with the easiest, gamma means immunoglobulins. So when you see electrophoresis pattern like this, where gamma, normally it was so small, has become such a big spike, what does that mean? That you have a proliferation of immunoglobulins, and when it is a single monoclonal immunoglobulin, what do we suspect? It is multiple myeloma. So this is what we call as the M spike. Remember, we call it M spike, but it's not IgM. That's a mistake so many students do. It is actually, again, repeating GAMD. So IgG monoclonal proliferation is the most common, presenting as M spike. Okay. On the other hand, what are the others? So here in alpha-1, you have all of these things. In alpha-2, you have all of these things. Beta is beta-2 protein. So you just give this a read. If I show you an electrophoresis like this, so black line is the normal one, but the patient has this pink graph where albumin has decreased and alpha-2 peak has increased. This is a repeat question. This is what we will see in nephrotic syndrome, particularly in minimal change disease, because we have seen that there is no structural change to the filtration barrier. There's only a charge change, and because of that, there is selective albuminuria, but the bigger protein will not be able to go out, and hence the alpha-2 increases. So this is so important, so conceptual, so nice. So this is what is nephrotic syndrome. And while we are at it and talking about proteins, I wanted to tell you this list as well. What are the negative acute phase reactants? There are many positive acute phase reactants like ferritin, then you have haptoglobin, many, long list. The shorter list is negative, means during inflammation, what levels go down. This is very cute because there are only two letters in everybody's name. So all I have to do is, if there is an A or there is a T, it is negative acute phase reactant. Example being albumin, antithrombin, transferrin, transthyretin, transportin. These are the negative acute phase reactants which tend to go down during inflammation. Everybody else is positive. Okay, so this is all about amyloidosis. Next, we go into independent pedigree analysis. This is a question you should never get wrong. We're going to study it in a way that you will always get this correct. Stepwise approach you have to take. You can't jump to the answer. I've seen people who just like look at this and say, yeah, mitochondrial head. Don't do that. Adopt a stepwise approach. What you have to first see is this having any gender preference and are all generations affected? If both are a yes, it is autosomal dominant. So no gender preference, matlab autosomal. It's not sex linked. All generations affected, matlab it's dominant. If you hear the word generation skipped, means I have to put in recessive into it, and because no gender preference, autosomal recessive. There's a very silly question or a very weird question that was asked in NEET 2023 where they give you like percentages of everything. So the moral of the story is 65% of the diseases are autosomal dominant, 25% are autosomal recessive, remaining are remaining. Okay. So if you're seeing a pattern that mother is only transmitting to everybody, mother gives to every child. Why? Because what does mother have that father doesn't have? Meaning, what does the ovum have that the sperm doesn't have? It's the mitochondria. So the mitochondrial diseases can only come. Mitochondria is the powerhouse of the cell. Mother is the powerhouse of the house. So mitochondria can only be transmitted by mother, and mother has no partiality. Mother will give to everybody. So this is what is mitochondria. Father giving to all son. What is it that only father and son have? Y. So that is what is Y chromosome. So this is Y chromosome linked. Now we have sex predominance. So this is where you will see that if father is giving to all daughters, you know that's how it usually is. Fathers are way more partial towards daughters. So father only giving to daughters, and mothers are usually very strict that okay fine, all kids will share. So mother giving to 50% kids. So this is what you have to remember is X-linked dominant. But if only males are affected and females are carrier, and look at this word, skip the generation. Skip means I have to introduce an R. So X-linked recessive. So did you get the pattern? Gender preference there or not will determine whether it's autosomal or X-linked. Generations being skipped will determine whether it's dominant or recessive. Just have to see these two things and your answer comes to you, and just two special things being mitochondrial and Y-linked. And if nothing, you know, suddenly out of nowhere a case comes, then it is likely a case of gonadal mosaicism. This will never be asked to you. Okay, so let's look at a few examples and try to adopt that stepwise approach. What do we see? Do we see any sex predominance predilection? Not really. So it is autosomal. Do we see any generation skipping? No. So it is autosomal dominant. So easy. Look at this one now. What do we see? This is mother affected, giving to every child. This male son didn't give it to anybody, but this female child again gave to both her children. So mother to all. This has the highest chance of getting asked. This is mitochondrial inheritance. Let's look at the next one. What do we see? Only males getting affected and generation skipping. So 1 + 1, X-linked recessive. Look at this one now. What do we see? We see that mother is giving to, this is the only child, so we can't really draw a conclusion. So let's see further. This is the male father who is giving to only daughters. So what does this become? X-linked. So this is what we have to do while solving pedigree questions. Next topic here are trinucleotide repeat disorders. Again, very, very important. One story we have to go over each one of them and we are done. So here, the first thing, what is the diagnosis? So this is a coronal MRI image and this is where the caudate nucleus usually lives and they're pretty large. But here what has happened is there is atrophy of the caudate. Whenever there is any atrophy of any gray matter, the ventricles are enlarged. Okay, so this is why the ventricles appear enlarged and this is called as boxcar ventricle. The disease where caudate undergoes atrophy, it is Huntington's chorea. So Huntington's disease, Huntington's chorea, what is it a repeat of? You will remember a story here, hunter trapped in a cage. So cage, what is the importance? Now with every repeat, we will make something associated. So hunter in a cage, you will remember that all the letters here go down. So there is caudate atrophy. Acetylcholine goes down, GABA goes down. So this is what you will remember, every letter of cage goes down in Huntington's chorea. The inheritance here is dominant, hunters are dominant. Cage has how many balls? 4 balls, so chromosome is 4. How are hunters usually? Hunters usually are very dominant. So the gene that you want to remember is Huntington. So remember, hunters are very dominant, they are trapped in a cage has 4 balls. That's what you need to remember. Two interesting phenomena which are not just for Huntington's but in general for all trinucleotide repeats are anticipation and Sherman's paradox. Okay, so both of them essentially have the same concept. So Sherman's paradox and anticipation, both of them say that as you keep going down in the generation, means suppose I have Huntington's, when I have a baby, my child will present with symptoms earlier and the symptoms are going to be more severe. So both of these are called as anticipation, Sherman's paradox. So remember these terms and they are used in association with all trinucleotide repeats. Their repeats keep getting longer in successive generations, right? So this is Huntington's. Look at this boy here. The boy has large ears. The boy also has large gonads. So this you will remember is CGG, congenitally giant gonads. And this is what is our Fragile X syndrome. So Fragile X is CGG, congenitally giant gonads. The inheritance is X-linked recessive. Some people also write as X-linked dominant. Chromosome obviously is X chromosome and the gene is FMR1. And that also tells you that there is familial mental retardation. In fact, this is the most common cause of familial mental retardation. Okay, so this is about Fragile X. Next, who is this man here? So this is a story that runs through various sessions of BTR. So we remember from OBGYN, and you will see this, that there we had a mnemonic called HAIAN. So this is your triple strain, and inhibin A was your quadruple strain. Okay, so if you don't get this right now, it's okay. We'll study this in OBGYN. HAE, HCG, alpha fetoprotein, estradiol. These are triple strain. Inhibin A is quadruple strain. So if somebody comes to him and says, hey, I am. So this is what is HAIAN. To be continued to the pediatric video, PSM video, where we get to know the name of this person. Hey, I am. Who am I? I am DJ. What is I am DJ? Wait for it. It is suspense for now. This is what is the story of a vaccine manager. So you'll learn this in PSM. So there we got to know his name. So first somebody came, mystery man came and said, hey, I am. Who are you? He said, I am DJ. And he asked him, what do you do, DJ? And DJ said, shaking your hand. Right? As in, hey, I am. So shaking her hand, and he said that I am a proper gunda. Does it ring the bell? Yes, orthopedics people are. Remember handshaking cast? What was handshaking cast? That was Coley. So in Coley's fracture, we do the handshaking cast. Handshaking means thumb has to be free. And the sequence was pronation, palmar flexion, and ulnar deviation. So proper gunda. There's a sequence of traction in handshaking cast. And now the final story of I am DJ. So then we have a boy called DJ who's coming and shaking her hand, but he's a proper gunda. Imagine a proper gunda. So this is DJ. So now we look at DJ. Does look like a gunda first of all. Will the gunda leave your hand once you shake? Will not.